Okay, it's 11:02, so we can go ahead and start. Hello, everyone. Thank you for joining the Family Centered Care Task Force 9th webinar. We are excited to welcome you all for 3 amazing talks today. I'm Dr. Malathi Balasundaram. I'm a neonatologist and one of the task force co-chairs. I want to thank Dr. Bob Chico, one of the FCC task force small group leaders, and is very active small group leader and executive member, and he will share the task force progress and moderate the second talk. And I will hand it over to Bob. And Bob, please take it away.
Thanks, Malathi, and welcome to everybody on the call. Malathi and Morgan and I will kind of tag team at the introductions and everything today. But as always, we have to start out by giving a bunch of shout outs. Because the work that this task force has done could not happen with all the people that that are putting in their time and their energy and their passion for it. So Morgan, if you can go to the next slide. There we go. And we none of this can happen without the fearless leaders that are shown on this slide. Our co-chairs, Malathi and Kira and Colby, put in so much time and effort and everything. And I have to say that Morgan has stepped into Carolyn's shoes and hasn't missed a beat for all the hard work and everything that she's done. And I think every day we had to thank ourselves for having this leadership team, taking this task force to higher and higher levels, as we're going to see on another slide in terms of how much it's progressed. Next one. And we couldn't have done this without, and just for everyone to notice the number of organizations and the breadth of the organizations that have been organizational partners with us is so impressive when you think about how extensive this concept of providing family-centered care is to the well-being of all the families and babies that we wind up serving. And I think for us to think about how many of these organizations and how broad these organizations are in terms of what they advocate for is just very impressive. Next. And we obviously could not do any of this work without some sort of funding. And these webinars can't happen on their own. They happen with a lot of hard work from everybody, but also the financial support that we get from both Genentech and Prolacta. This couldn't happen without that. Next. And then we get to the heart of this whole thing, because we have such a dedicated and extensive number of family partners, and they are constantly working to make sure that the small groups that we have are staying active. And we also, with the family partners that are making up the family council, we have the healthcare partners, who are shown on this slide. And I have to say that this is a perfect example of why we do family-centered care. When you think about how how our family partners and healthcare partners work together in such a collaborative way. This is what we mean by family-centered care, and it's nice to see that. I think that our executive council really models what we mean by family-centered care. Next. In addition to that, we have our committees, and the work that Daphna and Vargobi and Carrie have done, both with marketing, newsletter, and advocacy. We're going to get into advocacy here in a second. But the work of all these committees has been exemplary, and I think we need to really think about how much everyone is putting into this, and you're going to see an example of this on the next slide, because the work that the advocacy committee has done. All 3 committees have been extremely active, but this, it turns out, is a very time-sensitive thing. Because of the work that has gone into the advocacy, we now have, and I'll give a little brief summary of why this is important. The American Academy of Pediatrics every year has an annual leadership conference. At that conference, there's resolutions passed that actually guide the policy making of the American Academy of Pediatrics. All right. And thanks to the work that has been put in by Colby and Carrie and Nicole and other people that have helped to support this, we have a resolution put in for this year to promote the value of parents as family caregivers. And you can see here in the title of this is Parents and Family Caregivers Are Not Visitors. But if you go down to the resolutions at the bottom, you'll be able to see, and it's a little bit small type, but you'll be able to see this. And it basically would, if this passes, and especially if it passes and gets a lot of support, it potentially will guide the American Academy of Pediatrics in terms of formalizing policy that will cement the fact that parents are not just visitors, but parents are essential caretakers for their babies. So what I'm asking everybody, and the reason this is time sensitive, is that comments need to be put in for this by tomorrow. So anyone who's on the call that is an American Academy of Pediatrics member, I urge you today to go to the AAP website and put in a comment to support this resolution, because the more support that it gets, not only is it more likely to get passed, but it's more likely to be highly ranked, in which case it would go directly to the board of directors of the Academy to implement this resolution. If you're not an American Academy of Pediatrics member, there's a QR code on here, and take a second to look at that QR code, because it will take you to a Google form that you can complete, and Malthi is going to collect all those Google forms and put into her comments tomorrow. So I really urge everybody who's on this call, if you're an Academy member, just go to the website and put in your comments. If you're not, scan that QR code right now, put in some comments, and we can get more. The more and more people we can get to do this, the more likely it is that this will become a prime mover. We all realize how important this resolution is to families and that we serve, but we need to make sure that the Academy stands behind this too. And again, thank you for the work that the Advocacy Committee has done in making this happen. Next. The next thing I got to point out, and this is another QR code, different QR code, but this will take you to the task force website. And anyone who hasn't visited the website yet, I really urge you to be able to do this, because there's so much information there and so much help for people. And I want everyone to take a second just to read the text that's on this slide. When I mentioned before the work that both the Executive Council and especially our team, our leaders have done, think about how fast this group has grown. A year ago, we had 50 individuals. Now we have over 500. The work that everyone has done in terms of spreading the concept of family-centered care and recruiting people who believe what has to happen and the change that needs to happen has extended so much because of this task force. And I think visiting the website will allow you to understand why that is. So I really want everyone to appreciate how rapidly this movement has gone, and the reason for it is because of the hard work that so many people on this call and that have been involved in this task force have taken on. Next one. And finally, to end up, and before we start, because I don't want to take up too much time to go into our speakers and everything, but just to mention, there's a couple conferences that we should all be aware of if you're not already. The first is the International Family Integrated Conference, the FICARE conference that we held in Toronto at the end of September. I know that there's information for registration, but you can, if you just look up FICARE, you'll be able to get that. And next one. The next conference is not until March next year is the Gravens Conference. I hope most people on this call have attended at least one Gravens Conference. Having been a long-term attendee of this conference, I can tell you that it is one of the best conferences to really talk about why families are so important in terms of the care that we provide. I will point out that the Gravens Conference has already put out a call for abstracts. And what I would ask you to do, if you're a small group leader or you're active in a small group within the task force, if there's work that you've done that you think might be worthwhile sharing to everyone at the Gravens Conference, think about bringing this up in your small group and seeing whether or not there's a way to put this in an abstract. You'll be able to take your work to so many people, through the Gravens Conference. Next. I think that's about it for introductory things. I'm going to throw it back to Malathy now to introduce our first speakers.
Thank you, Bob. It's always wonderful to hear from others about how we performed. Thank you for that. I'm pleased to introduce the first talk speakers, Dr. Melissa Scala and Dr. Eilish Byrne. Dr. Scala is a clinical associate professor of pediatrics at Stanford School of Medicine and neonatologist at LPCH, and she is a medical director of inpatient infant developmental care and medical lead for the small baby unit. Her primary research interests are understanding the best care practices and physiologic mechanism of family-centered neuroprotective developmental care. She collaborated with Dr. Eilish Byrne, built this rainbow pathway that you're going to hear. Dr. Byrne is an assistant professor at the University of St. Augustine for Health Sciences, and she is a board-certified pediatric specialist and a certified neonatal therapist. With over 20 years of bedside clinical experience, Dr. Byrne is active in conducting novel research in the NICU setting, which she presents nationwide. She is a physical therapist at El Camino Health, as I'm so happy to collaborate with her to deliver the best care to our babies. And Melissa and Eilish, thank you for sharing your work. Please take it away.
It's a joy to come and talk to you guys today. I have known Malathy since she was not that long out of fellowship, and it's just been amazing to see how this work that she's spearheaded has grown. And it's great to see so many wonderful names on the chat who are here, folks I know, and folks on the board and family representatives and things like that. It's I think this is amazing work. So we're very appreciative for being here. We're going to talk today, though, about the iRainbow, which is our developmental care guideline that we use at LPCH and at El Camino. And it seems to be sort of spreading all over the country. The Vermont Oxford Network is doing a NeoBrain collaborative effort on trying to improve neuroprotective care, and our guide seems to have taken root all over. So it's wonderful, but we're happy to share what we've done. And if anyone on the call wants to learn more, we're happy to talk about it offline. Next. So we're going to talk about how we developed it. The first thing is really that we did an extensive literature review. So when I first came to Stanford, we realized that we needed better guidelines on how families could participate in care, because there was just way too much variability, and that wasn't good for anybody. So Eilish and I sat down to put together something, and we merged elements of an infant care path that she had created with some things that I was working on. That we presented the initial version of the iRainbow at Gravens in 2018, and we incorporated feedback sort of all along the way to guide our development. Next. So phase one, when we were rolling it out, we first started at LPCH with in-person instructional training. And this occurred in the spring of 2018, We got to educate all of the nurses at LPCH through their annual educational sessions. And then we did just-in-time training at the bedside so that as they were beginning to implement it with real babies, they had some understanding of how to use it. Next. And then in phase 2, we actually worked with the parents at the bedside with the tool and asked them questions about it. The whole time we were getting parent and nurse feedback, and we were tracking developmental care rates. So in our unit, when we opened our small baby unit in 2017, part of that was a focus on neuroprotective care. So we've been charting routinely developmental care activities since then, as just part of what the nurses do at the bedside. So when they're charting respiratory rates and blood pressures and things like that, they also chart developmental care. Next. So what happened with the parents when we were rolling out the iRainbow is the developmental care team sat down with the parents and went over the iRainbow. They had a written tool that they were given. A lot of them carried it around in their diaper bags. There were some pictures that are associated with it so they could understand what the activities were. And then we asked them some feedback. Next. So after they were able to use the iRainbow for a bit, we went back and asked them a few questions. And this is just 2 of the things that we asked them. But luckily, pretty much everybody felt like they interacted more with their baby because of use of the iRainbow and would recommend it to other parents. Next. And one of our goals in our work was to try to reduce disagreement in healthcare staff. And because this was some of the impetus of our getting started with this creating this tool. And you can see here that pre-implementation, we were surveying our staff about how often they were disagreeing with each other about what the best developmental care activity was for a baby. So blue here is pre-implementation, orange is post-implementation. And unfortunately, you can see that pre-implementation, our bedside nurses were arguing with each other about developmental care almost 60% of the time. This is not the healing environment we were looking for, but it really spoke to people's not having a guide for what to do when, and people using their judgment that may create bias and disagreement. And then some people were passionate about doing developmental care activities. And so this was all leading to conflict. Luckily, that after we implemented the iRainbow, these rates significantly dropped. We still sometimes have disagreement, clearly, but we had a statistical shift from often to sometimes as the most common answer. Next. Also, when you look at rates of developmental care, here we are examining a group of babies in our small baby unit, because that was a group that was in a hospital for sort of a good length of time. They had sort of standardized developmental care needs, and it was a good cohort to see how we might have affected developmental care rates. So before we implemented the path, here is our sample. They were average around 26 weeks. We're pretty matched pre and post in our groups. Next. And with the care path, we were able to statistically increase total rates of developmental care, particularly by nurses. The total rates of developmental care by family did not reach statistical significance in this small sample, but we think these are clinically meaningful increases in total minutes per day. Next. And if you look at specific activities that we chart, kangaroo care, again, did not reach statistical significance, but that's a clinically meaningful increase in minutes per day. I can say that particularly because some recent research we just presented at PAS that's under review for publication showed that a 15 an extra 15 minutes per day of kangaroo care in preterm infants was associated with a 15-point increase in IQ at 12 months of age. So even a small increase in kangaroo care can make a big impact. We did statistically increase swaddled holding. And again, we're seeing clinically meaningful changes in containment touch. Infant-directed speech, it remains low. It became an area of focus for us to improve care. I think people really got into the healing environment, and I think need to be encouraged to understand nutritive sound. Next. I'm now going to turn it over to Eilish. She's going to go over the iRainbow.
Thank you, Melissa. All right, next slide, please. All right, so the iRainbow, can everybody hear me? Okay, thank you. So the iRainbow is most appropriate for infants who are less than or equal to approximately 44 weeks postmenstrual age. What is unique about the path is that it considers the cardiorespiratory stability and physiologic maturity of the infant, and it actually does not rely on gestational age. It uses 6 color-coded stages of advancing infant stability, and each stage has associated recommended evidence-based developmental activities. It is on a continuum, so it allows for the infant's change of status. They can move up and down on this path quite easily, as we know many of them will. And it also allows infants to enter at any stage. So you'll see here when I describe stage 1, which is for the sickest infants, many infants will not enter at stage 1. Next slide. So the staging is very quick, and you'll see when I present the clinical criteria for that, but it's really based on the infant's response to sensory intervention. So touching and talking and how the infant's responding to that is how you stage the infant. Infants who are clinically less stable will benefit from more frequent staging. So perhaps at every care time or every shift. Once infants get into the later stages, you'll see intuitively this will make sense. So for instance, stages 5 and 6, those infants can just be staged once a day. Next slide. Okay, so stage 1, it was important. So with my work at Lucille Packard Children's Hospital, Stanford, it was important for Dr. Scala and I to have a path that started with actually including the very sickest infants. What we have found in our years of experience is that often those are the infants that, you know, are the touch-me-nots, don't talk to them, don't look at them, stay away from their bedside, they're so sick. And what we realize is that it takes like a long time to actually then get re-involved with those infants. Maybe a week or 2 goes by before you realize, oh, I should have been actively doing something, you know, with this infant and with this family. So this is the infant that we're trying to capture here. This is the highly unstable infant having severe episodic bradycardic and desaturation events in response to minimal handling, just the handling it needs for care is this baby. This baby, once disturbed, then requires multiple interventions to recover to baseline. So maybe bagging, a suctioning, other escalation in respiratory care perhaps. And they take a while to recover back to baseline, more than 10 minutes. This is the infant where you really want to limit external environmental stimulation. And if you go to the next slide, we'll see what else you can do. For the parents, they can start to get to know their baby, and they can start comforting their baby with smell. So this is, what are the developmental activities we recommend for these infants in this stage? Parent education. Get the parent as comfortable as possible, as quick as possible to the unit, orient them to their infant, introduce the use of scent cloths so that the parents can start comforting their baby with smell and also be comforted by their own baby's smell when they wear the cloth, and manage the environment to promote rest. Also behind the scenes, you know, we'll be optimizing positioning for comfort and respiration, musculoskeletal alignment, and things like that. This slide that you see here is very close to what we use at El Camino to be the parent facing slide. The slide with the clinical criteria is what we see, only the providers see. We don't have the parents looking at that information. Okay, let's go to stage 2. So the provider facing slide, what is stage 2? This is an infant having less severe episodic bradycardic and desaturation events, again, with handling. They don't require multiple interventions to recover, but just one, and they return to baseline more quickly. Next slide. Here, we encourage parents to really start observing what their baby likes and dislikes and start calming their baby with touch. So this is a great stage to have the parents involved in containment touch and forehanded care, really starting to get them comfortable helping you as the nurse, or when I'm in there as the physical therapist, helping them contain their infant and starting to feel really competent touching their infant. We want to continue to promote rest for infants in this stage, optimize positioning, and using scent cloths. If an infant enters at this stage and is not entered at stage 1, you would still introduce the scent cloths at this stage so that these parents can start using that as well. Next slide. All right, so the infant in stage 3, excuse me, is tolerating containment touch well without desaturation or bradycardic events. Go to the next slide. This is where we'd like to introduce voice to the infant. So by that, we're talking about intentional voice. So this is where you actually open the portholes, get down and try to engage the infant in a conversation. So you're trying to get this infant when they could be more alert and actually able to listen to you. I'm not talking about the ambient talking that we might be doing while we're doing the infant cares. So we'd like to introduce intentional voice here. The parents are continuing to provide the containment touch during the baby's care and as needed throughout the day. This is also a great stage to have the parents do the diaper changes if you've been already working with them on forehanded care. If they're just entering at this stage, please do the forehanded cares with them first to get them really comfortable and competent in that, and then really, have them be more independent in diaper changes for the infant in stage 3. Continuing parent education, using scent cloths, still optimizing rest for this infant and watching positioning is still really important. I'll pause here just to say, we intentionally wanted to give these infants in these lower stages who are sicker the opportunity to respond to one sensory modality at a time. That is why we have it staged where you introduce voice, where you introduce touch and then layer on voice afterward. There is no intention in holding an infant back and moving forward on this path. But you can do this in one care time. So if you have an infant come in, you're not 100% sure, are they stage 2, are they stage 3, you're pretty sure they're not stage 1, go ahead, do your containment touch in stage 2. If they're responding really well to that throughout your cares, add voice. And if they're handling both of that, then they're in stage 3. There's no reason to wait until the next care time to kind of test that out. Okay, if you're pretty sure they're in stage 3, let's move to the next slide to see maybe they're actually also moving into stage 4. So the baby who's in stage 4 is tolerating the other developmental interventions without desaturation or bradycardic events. And they also are tolerating basic cares with minimal disruption. So they return to baseline within 5 minutes of having their basic cares done. So this is an infant that could be ready for holding, which is what we have as stage 4 here. And when you want to sort of test that hypothesis, see if they actually are ready for holding, you would do the transfer with the infant. And as long as they recover to baseline within approximately 15 minutes, we would say, yes, that is a baby solidly in stage 4. If after the transfer, they're really struggling still, 25, 30 minutes after the transfer, we would argue that they might not be quite ready and maybe restage them at the next care time. So what the parents see, you can show the next slide, please, is that this is the stage to start holding and enjoying your baby. So we recommend that people caregivers hold their baby every day as able. We would like to continue, obviously, the other activities of talking, reading, and singing to their infants every day, during cares, diaper changes. This is also where we like to add an opportunity for the infants to move on their own a little bit. So this is a baby who is stable and ready for a little time outside the swaddle. So I do recommend highly that around the diaper change, you pause and allow the baby to actually move his or her extremities to really work on that joint molding, which we as physical therapists and many other professionals know is lacking from loss of that fluid-filled environment that last trimester. So as we pause here for a moment on stage 4 holding, I want to just emphasize that this is a multimodal sensory stage. So this is going to be combining touch, voice, movement, more than likely. Obviously, the parents aren't 100% still. And then even maybe some vibration as the parents might be speaking. And so that's why, out of the respect for the infant and really trying to give them an opportunity to speak to us, we have the unimodal sensory interventions introduced in the prior stages to see if they're ready for that, and if it's something that they're ready for, and it's going to be actually a beneficial experience for them. But I want to emphasize again that an infant can enter in stage 4. So this doesn't delay holding. It just standardizes our approach to holding, which I know after many years at the bedside is needed. It shouldn't rely on necessarily nurse comfort at the bedside or the medical team who's on that day, or maybe some other more subjective factors as to whether or not an infant gets held. It really should be on, it really should rely on whether or not the infant clinically is appropriate for holding. Okay, next slide. All right, so the infants in stage 5, they tolerate holding well. They also attempt to engage you socially. We can go to the next slide. Yeah, so this is like my jam. This is where I just really start having fun. I'll just say here, many infants leave in this stage. They go home in stage 5. For the infants who don't, you'll see I do have a stage 6 here. So this baby is the baby that's ready for more developmental activities and social interaction. And the way I present this to parents is, this is really fun. This is a menu. This is like you're going out to dinner and you're going to choose what you're going to get that day. This is a really empowering stage for parents. It's a menu of options of what they decide and what they choose they want to do with their infant that day. The infant in stage 5 is ready for any of these activities. Probably not all of them on a single day, perhaps, but individually they're ready for those. And so, you know, it could be that maybe the physical therapist, I've gone in and done some massage with the baby. So maybe the bedside nurse has checked that off. Parents come in and says, oh, you know, the PT was here earlier. She had a great session massaging your baby. What do you think you'd like to do today with your baby? And maybe the parent will want a massage again, no problem. But maybe the parent will say, you know what, that's great. I'd like to do that modified tummy time that, you know, the PT or the bedside nurse taught me, or the OT. This can be used by other professionals. I am a PT, so that's why I keep saying PT, but forgive me. You know, working on the modified tummy time, it's meant to be a fun stage. I will just also point out here that the only real area where gestational age enters this path is at this stage for massage. We do still recommend that it's really most appropriate for infants who are at least 32 weeks. And that just comes out of some of the literature regarding IVH risk and the fact that, you know, when you are massaging, especially a small infant like this, you're really changing, you know, preload on the heart. And we want to make sure that the infant's really ready and appropriate from a physiologic perspective to tolerate that. Next slide. Okay, so the infant in stage 6 is the baby who you have a great time with in stage 5 activities. You've had a great session, it's been fun, you swallow the baby up, and you look and the baby is still engaging you. This baby is saying, don't go, I want more of you. Please play with me more, you know, so this is the baby that is in stage 6. So we can go to the next slide. Again, this is our fun menu of options. What do you want to do today with your baby? These activities that you see on this slide are really a progression of the activities from stage 5. This baby's ready for a little more strengthening in his or her developmental program. And that's what we have here. Yeah. I think the formatting on this got a little messed up in the transfer here, but kind of in summary about the iRainbow, it's descriptive, which I love. I think nurses love it too. If I tell you the baby's in stage 4, once you get used to it, you say, oh, okay, I kind of know what this baby's going to look like today. And that's really helpful. It's really great in a highly complex NICU where critically ill infants might not tolerate other, maybe more prescriptive care paths or programs. I can definitely tell you from experience at Packard, that's been difficult to really keep infants on track for those kinds of paths. It's modified. It's actually, we also have a cardiac iRainbow for infants in the cardiac unit who have slightly different clinical criteria defining theirs, or quite different clinical criteria defining their stages and different developmental needs. It is unique, as I mentioned. It's really focusing on the infant's clinical status, and then especially in the older stages, their behavioral and physiologic maturity as well. It is effective. We've shown it to be effective in our unit by increasing developmental care rates and also helping parents interact more with their baby. We, of course, would love to study that more. I think the parent piece is still, you know, low-hanging fruit for us to really engage them more. It is free. It's flexible and easy. It was important for Melissa and I to have this be free or very low cost. We have developed some more professional looking materials that hospitals are welcome to use very cheaply, or there are the free versions that basically I did, and I'm not a professional at formatting. It's also, as we said, easy to use, which we understand is so important, especially in units where you have high turnover or maybe lots of travelers coming in and out. It can be very difficult to sustain a program that requires, you know, extensive training prior to use. It's infant-led, it's parent-friendly, and it does standardize communication as well as our approach to developmental care, which I love. As a service who comes in and out, you know, that's been one of the most greatest difficulties for me in my career is trying to figure out who's at the bedside today and what I think I can do with the infant today based on who's at the bedside, rather than based on really what's appropriate for the infant. Okay, next slide. We want to thank, obviously, all the nurses and providers and parents who helped contribute to this work. Obviously, thank you for attending the talk. And I think we have one more slide. Yeah, so we are welcome to, we're open to sharing this with you. There's our contact information, and thank you.
Thank you, Eilish and Melissa. It's wonderful overview. And we are running out of time here, so unfortunately we don't have any time for the question and answer session. I do have one question. I just wanted to put it up if you guys can briefly answer. Are you using the iRainbow with the term surgical NICU infants? Or are you guys using that in LPCH? And
I tried to answer since you said there was no time. It's anybody 44 weeks at PMA and less. So yes. Yeah.
Okay. Thank you. Thank you. So if you have any questions or if you wanted their materials, so reach out to them and we will provide the email as a follow-up webinar email too. So their email, or you can put your email, Melissa and Eilish, so they can reach out to you if you want. Now I hand it over to Bob to introduce the second speaker.
Thanks, Malthi, and I'm really excited to introduce our next speaker. Daphna Barbeau is a neonatologist at HCA University Hospital and also directs their high-risk infant neonatal clinic at HCA. But in addition to that, and apropos for today, she is also the host of a podcast called The Incubator. And you might think that all that stuff keeps her like really busy. But if that's not enough, she's so passionate about family-centered care and providing family-centered care that she also has become a very active member of this task force, is an active member of the executive council. She's a small group leader. As you saw earlier, she is the chair of the Marketing Communication Committee, and is also very active on the newsletter committee. So, I mean, this should tell you a little bit about what Daphna brings to the table in terms of, her passion for our topic today. The topic today is social media, a tool for connecting with families, something that is, I think very much needed for us to learn about today. So with that, I will turn it over to Daphna and take it away.
Well, that was a very kind introduction. I appreciate that. I'm just happy to play a small role in the work that the Family Centered Care Task Force is doing. I'll share my screen. Oh, there we go. Now I can share. Okay. Everybody can see okay? Give me a thumbs up if you can see. Yes, okay.
That's good.
Okay, perfect. So my talk today is mostly targeted to our healthcare professionals because I think we worry, and I'll talk about that, about using social media to connect with families. I was hoping to have one of our parents join me today, but for a number of reasons that didn't work out for this afternoon. So if I have any remaining time, I'm really going to defer to some of our family partners so that they can have the opportunity to weigh in on the topic also. Because certainly there's a paucity of data on this interaction, but certainly in our NICU community, most of the articles on this topic are really commentaries. Oh, okay. You mentioned some of my disclosures. I am one of the co-hosts of the Incubator podcast. And my second disclosure is that I have a bias. I think social media is a useful tool in connecting patients and families. So I'm disclosing that I'm hopeful that I can convince you the same. I think we all are realizing that communication is changing. And this is really a graph of people who use a smartphone over time. There's 2015 to 2021. And it's changing significantly by demographic. So you can see this top blue line are 18 to 29-year-olds. This black line is the 30 to 49-year-olds. Gray is 50 to 64. And here, this bottom line is the 65 and over community. But you can see for the demographic that makes up the majority of our NICU families and parents are way up here. And in 2021, 95% own a smartphone. And here you can see this is older data here on the right side of the screen. They have up to 2011, but you can see that the number of text messages sent or received per day is rising increasingly. But this is also different dependent on the demographic. And I'm going to focus on the demographic where I feel most of our families are. I'll disclose I was an older mom, so I didn't fall in this demographic, but I'd say the bulk of our families do. And text messaging, you can see here, 95% of 18 to 29 year olds use text message features. And that's an average of 87 text messages on a normal day. Median was about 40 text messages. And the youngest group, those between 18 to 24, are using text as like the primary mode of communication. You can see that 18 to 24-year-olds send or receive an average of over 100 text messages a day. The median 18 to 24-year-old sends or receives 50 texts per day. And 1/4 of them report sending more than 100 texts per day. So when we really talk about communication and meeting people where they are, we know that people are spending a lot of time on their phones, and the way that we communicate, even in the medical sphere, has to change with our new societal norms. Thus, we know that there's an increasing use of social media over time. There are 4.65 billion social media users on the planet. Over 80% of Americans use at least one platform. And studies show that about 60% of physicians are using social media to find medical information and communicate with peers. But we know that our patients and families are communicating on social media. And there's some data, not in the NICU necessarily, but to support how this physician-patient relationship is changing. We know that many people are using social media as their primary news source. That's one big feature of social media these days, but over 80% of internet users are using it to seek health information online. There are a number of studies that looked at how we engage patients on social media, again, not in the NICU, but it's improved participation in care and adherence to care plans. And this article did a very nice job also in showing that some of our highest risk patients, the ones that lack the most resources and have the most barriers to care, transportation, financial, time off of work, childcare, those may be the people that benefit most from obtaining information on the internet and through social media platforms. We know that the neonatology community is using social media, and we don't have a physical study on this information, but we, my partner Ben and I, give a lot of talks on social media for neonatologists, and these seem to be the major reasons that people in the neonatal community are using it. We use it for personal use, obviously for education, case studies, medical literature, new policy statements as a way to communicate with one another, a lot of opportunities for professional education, engaging with other professionals, and as a tool for research. And we know that our Neo Twitter, or the group of neonatologists and neonatal healthcare professionals on social media, is growing. And if you'd like to join us on social media, or if you are using social media but you're not really engaged with the neonatal sphere, this is the hashtag we use on Twitter, hashtag NeoTwitter. And you can see that since the advent of the hashtag, which was actually just mid-2020, and you know, a lot of people stuck at home probably helped us propagate the hashtag. But you can see that over the following year, our collaboration and participation with one another on social media has grown exponentially. And I'd say in this last year, where you don't have this data, it's growing even faster. And yet we know that physicians are hesitant to get onto social media. And there are a number of reasons for that. This was one of the articles that looked at barriers to physicians and other healthcare professionals engaging on social media. Today, we're really going to focus on how that relates to our patients and families. But one of the primary concerns is maintaining their own privacy and maintaining the privacy of their patients, and protected health information like case reports, case scenario, patient cases. And the other is concern that their personal professional communities, like their places of employment, may not be accepting of their social media use. And I'm hoping I'll argue to you all today, what are we so afraid of? I'll say this happened to me just this week. If you follow the podcast on Twitter, or you follow me on Twitter, I post a lot about developmental care. I was so excited that we've been using the Sense program by Bobby Pineda for some time, but we had changed the Sense booklets into this flip booklet that are standing upright at each bedside, and that was working really well for us. I was really excited about it. And it got a lot of traction on NEO Twitter about using the program and how people were using it, what languages it was available in. And I've blurred out the name for just privacy, but one of our patients, an active patient in our unit, does not follow me on Twitter. I don't follow them on Twitter, but saw the post. And they mentioned that they were grateful for the care they're receiving in our unit. And when these interactions happen, I liken them to when you're in your home community and you bump into a patient, say at the grocery store. You don't tuck behind the aisle and hide and try to pretend you didn't see. Well, maybe some of us do that. But in general, I think that we can have personable conversations with our patients and families, even outside of the unit, that maintain both personal and professional boundaries. And that's how this conversation went. I responded to her, thank you for your comments. And then I responded her in person because I didn't want, it's not my place to disclose if this is my patient or we're caring for this patient or what's happening with this patient. And that's the same thing you would do if you ran into somebody with others at the store or downstairs in the lobby at the hospital. You don't disclose any active information, but you can still have a cordial interaction with people. I understand, and obviously we've identified some potential serious pitfalls to social media communication. The first of which is maintaining HIPAA first and foremost. Obviously there are concerns about blurring of the patient-physician relationship and this concern over loss of physician trust. So the first two, I think as long as we navigate social media as if we were having in-person communication, just like we would in the hallways in the hospital, the lobbies, the cafeterias, when we bump into our families out in the community, we should have the same types of interaction on social media. And really this concern over lack of physician trust. So actually this has been studied well in patients, not our neonatal community, but the biggest concerns and lack of physician trust is when physicians have been behaving poorly, let's say on social media, making comments that probably shouldn't be said to anybody anywhere, but certainly not people in charge of the health of others. And so my biggest recommendation is to conduct yourself on social media as if you would in person. We have such a amazing neonatal community that I have less concern about this loss of physician trust, but knowing that we all have to be very careful about what we share on social media. There are some professional recommendations. So the American Board of Pediatrics highlights obviously protecting public health information. They do discourage physicians from quote unquote friending patients or families on social networking sites, but they really advocate for helping families connect to other social communities and information on the internet. The American Medical Association also has similar recommendations, encouraging physicians to separate their personal and professional information online. And one way we can do that is having different accounts for different reasons, one for professional, one for personal. Some people use different social media sites or platforms entirely, one as a professional identity and one as a personal identity. And also changing our privacy settings so it manipulates who can see what. And then again, they just recommend that you engage on social media just like you would in the hospital. But the truth is, parents are looking for reliable information, and this demographic of parents are consuming information at an astronomical rate. Parents are bombarded every day by a variety of sources telling them polar opposites about what they should do to care for their babies. And parents are confused, rightfully so. And so some might say we have a real responsibility to help parents navigate the information that they see on the internet, because the truth is information is out there, and as physicians and healthcare professionals become more reluctant to join the conversation, we know that families are seeing more and more incorrect information than they are correct information. So it really takes our community stepping up and engaging to help correct some of the misinformation. We have some great neonatologists actually in our sphere. The Incubator podcast does have some parent followers, but truthfully, it's more an educational resource for healthcare professionals. But Dr. Narvi, Dr. Prem Fort, Dr. Athif El Kufash, they all have major followings on YouTube, Instagram, TikTok, and through Apple Podcasts to provide good, reliable information to families. And so that's really coming from the neonatal sphere. There's also a whole host of nurses, PT, OT, speech therapists who are engaging with the neonatal community on social media. And we know that families are looking, like I said, for this information. This particular study was one used on the families' use of basically family organizations. And nearly 60% of the parents surveyed were using family organizations to connect with other families and get information. And in general, this didn't interfere with their engagement of their home clinicians and their NICU. There are so many ways that we can engage parents and families on social media. I think the biggest of which is advocacy. We can provide information about opportunities for families, for our local communities, and we can partner with families on topics that are important to them. And we know, especially in the current political climate, that our advocacy is more important than ever. We can engage with families on research, both in recruiting families who want to be a part of research and helping families who are looking for specific research and clinical trials to have more access to that information, not relying on a specific team to be able to provide that information to them. And for our families who are doing the work and engaging in research, being able to give updates on how that work is going. We know communication is really, really important in the NICU. I loved this 2021 article that gave a kind of communication framework for the NICU. And it broke it down into kind of the top 4 types of communication we have in the families. With families: building, maintaining relationships, exchanging information, shared decision-making. And then this last piece about parent self-management. So parents becoming parents in the NICU. And one of the places that we really struggle, I think, because we're always trying to balance this line between professionalism and our boundaries is this building and maintaining relationships. And a lot of data collected by parent groups and focus groups show that parents really enjoy this chit chat, getting to know the medical providers and professionals, and us getting to know them, asking about them. How's their day going? What are their resource limitations? How are their other children? This really changes an interaction and helps to mitigate some of the stress in the NICU. I would argue that social media is one way that we can target all of these topics. The paper specifically identifies some hidden opportunities. That's the chit chat chatter, asking about the parents' well-being, unit-wide conversations. So if you have something special going on in your unit, and is our information that we give families consistent? And so I'll talk about a way we can do that in just a bit, because I think one of the futures of social media in the NICU is facility-specific forums. And some of your NICUs may already be doing this, and I applaud you. I think this is so important that I will disclose this is a neighboring hospital to my hospital. This is not my hospital. In fact, some might say it's a competitor to my hospital, but I think this is so important that I wanted to highlight their use of social media. I can see Barbara Glassman is on the call, and I know she helps add some of their content from the NICU. But you can see this is a reputable source for a community to go find safe information that's just in time. So these were pulled recently. They're related to the summer heat. They're related to new toys that toddlers play with. So they're kind of providing real just-in-time information. And I think we can do this on an even smaller scale, so to speak, by doing it for individual NICUs. They also even have a social media giving campaign, which I think is a really smart way to invest back into our units. There are people in our community who want to give and support the NICU, and there are families who want to give back. And this is an opportunity for people to do that in a very easy way. And we're all here, I think, in the Family-Centered Care Task Force in the search for goal concordant care. And I think that we can't really say that we have goal concordant care if we're not asking parents what they want. And so I see a lot of people in the community giving these parent groups and networks, many of whom participate in the Family-Centered Care Task Force as a resource for parents. But I implore our medical professionals to consider them a resource for yourself as well. I think by looking at the posts and seeing what our family partners are doing, we can really start to understand what's important to families both inside and outside of the NICU. We really start to see where we have lapses in resources and communication and what our families really need. I really like this. This is the Canadian Premature Baby Foundation, and their resources are really simple. But when we think about what are the most common reasons people bring their babies back to the ER, or they're seeing pediatric follow-ups, things that our neonatology team is not managing, sometimes we miss the boat on what is the right anticipatory guidance. But by following parent groups, maybe we can hone in a little bit better on what's important to families. And certainly family organizations have shaped the face of medicine, in particular neonatal care. This is the SOFT organization. It's a network supporting families whose infants have the trisomies. And certainly they have been advocates for their children and their healthcare teams to change the way we think about managing these types of syndromes. And it's really changed the way that we care today. So real change is happening by families engaging on social media and the internet. And this is another example. The Next Society, I think, is another place where we see engaged parents really changing the narrative, and in the terms of the Next Society, changing our research goals so that they better align with what families want and need. This is a baby in our unit. This is baby, she's not in our unit now. This is baby Ella. I have permission from her mom to share her pictures. But this is a family that post-discharge, and I'll talk about that in a little bit, I follow on Facebook. And not all of my colleagues will agree with that. And I think when we talk about goal concordant care, when we talk about individual unit practices, and we talk about the outcomes coming from individual units and knowing our individual communities, I think this is a great way, again, that we can understand what's important to families, and we can see how our clinical practices play out in the long run, not a month in, not at discharge, but over time as our infants are now growing and developing into toddlerhood. There are many of us who participate in neonatal follow-up clinic, but even that is just a small snapshot of what those babies can do. And this seeing videos, seeing, interactions between siblings is something that we just can't replicate in the clinical sphere. And so baby Ella, you can see she had a complicated clinical course, a lot of complications, and she's developing happily and successfully. So given all that, what are my recommendations for interacting with families on social media? Obviously, HIPAA should be at the top of our concerns, and we should treat private health information, protected health information, just like we do in the hospital. We don't disclose patient information. We don't acknowledge patient care that's been done. But I think we can still communicate and chit chat with families. I think it's up to the families. I think we should not reach out for families, but allow them to reach out to us. I think our communication, like I said, should really consist of this hallway grocery store conversation. And in my personal practice and based on professional recommendations, I really do wait until after discharge and the termination of the patient-physician relationship. But I think there are a lot of benefits, both for the family and for our clinical teams, in communicating post-discharge. This also means that we don't provide medical advice on individual cases, even after discharge, right? We refer them back to their current clinical teams. And certainly separating personal and professional accounts is a very good idea. We know that our families are curious too. They don't know how to engage with us on social media either. And Hand to Hold actually did a great blog post with basically the flip side and the same information. Waiting until discharge, asking permission, using lists to change our privacy setting, and maintaining those same boundaries that we had in the hospital. I think there is a future for social media use in NICUs. I'm hoping more NICUs will take advantage of their facility-specific sites so that they communicate with families. Families get more consistent information because everybody's getting the very same thing. I think it can help our families connect in a different way. And we know that peer-to-peer support is one of the most valuable things that we can offer to families. I'm hoping that by more people engaging, we have more reliable information. We help families connect to national and local networks that are specific to their needs. And that we just develop a less fear of engaging with our families online and kind of personally in person as well. These are my takeaways. Again, social media, I think, can serve as a tool. We need the voices of trusted professionals available to families. Communication should always be consistent with what the parent and family wishes, and communication should be done as if in person. So I don't know if we have any time left, but I see we have some family members on. I don't know if anybody else would like to weigh in.
Daphne, unfortunately, I'm not so sure we have any more time because we have one more talk. So
maybe they'll leave their thoughts in the chat.
But anyways, reach out if you have any questions. I will say, Daphne, that I appreciate when people say not to your job as a physician isn't to make friends with all your patients, but when people talk about partners or when people talk about just keep it professional, what we really need to be talking about is partnership, and so. And I'll leave it at that. So, and Morgan, I will turn it over to you for our last speaker.
Thanks so much, Bob. Let's see here, share my screen again. All right, so I am going to be introducing Maureen Fura. Maureen is the CEO and founder of Mammha. Mammha is a health tech startup in the femtech space created to leverage technology and innovative care delivery to target gaps in the diagnosis, prevention, and treatment of perinatal mental health to ensure no woman slips through the healthcare gaps. I will turn it over to you, Maureen.
Thank you so much. And should my slides just run on the screen and I'll just let you know to flip through? Awesome. Okay, so it is so, what a great opportunity to be here with all of you today. I've learned so much. So thank you for giving me this space to share a little bit about what Mammha does. I created Mammha as a mom who slipped through the gaps when I was pregnant, and felt immediately like something was wrong. I didn't feel like myself, never had a mental health crisis in my life that I knew of. Looking back, I can see anxiety was in there. And I told every single doctor I came in contact with something was terribly wrong. And I didn't think I was going to make it to the end of my pregnancy, or I would probably take my life soon after having my son. And it took 190 days to find help. And no doctor knew what to do with me or what kind of care I needed or what it was called. So really created Mammha to create a system solution that starts with physicians, health systems, hospitals, NICUs, and really ends with parents, to be able to increase screening scores, and then also increase engagement by parents into treatment that really helps support them. So next slide. So as all of you know, I am sure, NICU parents are most at risk for developing these perinatal mood and anxiety disorders. And when I started 2 years ago with Mammha, it was really focused on women and mothers. And we have started to screen fathers in the NICU now and are noticing high rates of suicidal ideation, which has been kind of shocking for me in my journey and understanding that we can't just focus on mothers, but it also fathers, parents together. So research says 28% to 70%. I'll let you know, Children's National in Washington, D.C., we screen there, and we do remote screening for them. The rate has been around 32%. We're screening in Virginia's Northern Virginia NICU through Innova Health System, and the rates since we started in three months ago have been 46% and increasing every week that they increase screening. Next slide, please. I will say that we also screen in pediatric offices and with OBGYNs with non-complicated births. And if you can see, these are the scores that we get. So on the right side, it's pretty predictable. It's this like nice clean slope. Most mothers are doing okay. And then it follows the up to 20% of women will have these mood disorders. If you look to the left-hand side, this is what our NICU screen scores look like. Oops. Oh, the other slide, the first slide, sorry. And you can see they're kind of all over the place. There really isn't a pattern. They're up and they're down and they're over. There's a lot of stress. There's a lot of trauma. And so it's coming out in those scores that we're seeing. This is a unique population. Next slide, please. So we know there are so many impacts of untreated maternal mental health complications. One of the most important things we're searching for is suicidal thoughts, suicidality. We know that women are at a higher chance of attempting suicide around the 6 to 9 months of in the postpartum period. It is a leading cause of perinatal death in the postpartum period. So one of the really big things that we're doing when we implement Mammha is we're screening for that suicidality, how often they have those thoughts. We use the EPDS, just so you guys know. So it's a validated screening tool. But there's attachment issues. There could be depression that's left untreated and it lingers. So there are so many things that are going on. And as we've heard today, you need that touch and that interaction from parent to baby to activate, neurons and development. And I even heard like some babies get higher IQ scores by the touch and the kangaroo care. So it's really important. Mental health plays a key role in all of that. Next slide, please. So what Mammha does is we took that paper screen that so many physicians and health systems use, that Edinburgh postnatal depression screen, and we took it off the paper and we put it on inside a digital kind of one-stop on your phone app. And what this does is it's where these moms and dads are most comfortable. They're digital natives. They know their scores aren't being shared around the office. Nobody has to tabulate those scores. And so what Mammha is we screen and then we immediately connect them in a pipeline of support that Mammha will take care of everything after that positive screen for a mother or a father. So next slide, please. So screening happens on the phone. Every office or hospital system, they get a unique QR code that's connected to their in-unit social workers, or if you're a unicorn NICU and you have an in-unit therapist or a charge nurse, these people are getting the screening results. So the parent takes it on their phone when they come into the NICU. We have a different couple of NICUs, the way they use it. Either the social worker gives out the QR code or the charge nurse pairs it with another piece of their workflow to make sure that parent gets screened when they come in. It comes in Spanish and English in our screening platform, but we're considering adding other languages depending on where we're working. Next slide, please. So once that parent screens, those results can go back to whoever the NICU or the unit wants to get those results. Mammha is also getting those results, and that's because as soon as that positive result happens, then we're notified as well at the same time, so we can coordinate all that follow-up care. But it comes through in either an SMS message or an email, and then you have access to all of those results. Next slide, please. And we learned that what physicians and providers need, we don't really know how to talk about it. Oh, it's the slide before, sorry. And so we gave enhanced screen results. These results have talking points, they have triage phone numbers, and they come with all the patient's answers. And then those can be uploaded to EHR and they can be stored. And so you have access to them. Next slide. So parent has taken the screen, results have gone back to the right people. Let's say the parent screen negative, they get access to instant education. It comes right through right after the screen. It says, it looks like you're doing well. Just want you to know about some of the risk factors and what to kind of watch out for. And if you do feel like you have noticed any of these changes in your mood, you can reach out. We give them a link to reach out to. We also know that women and men sometimes don't feel comfortable being truthful in these screens. There's a lot of fear and a lot of stigma. So after someone takes a screen and it's negative, they get a follow-up SMS that says, if you would like to connect with care discreetly without letting anyone know, they can reach out in this other very simple way. So we give them kind of two pathways to engage in care, either screening positive, or they can connect without letting everybody know that they're having a really hard time and they would like some support. So the next slide. So let's say the parent screens positive. They're going to get three things immediately. So the first thing is they're going to get access to this kind of parent portal. This portal is trauma informed, so it's not a lot of writing. We're not overwhelming their brain that's already in this shock trauma response. We're giving light education. There's tips in there, sleep, there's tips in there for self-care, how to talk about it with your family members, what to expect. And so they have access to that and it comes right away. The next slide, please. After that, they're signed up to get these automatic CBT and coping skills SMS text messages. They can opt out of it at any time. These are a nice way to give these digital kind of, I call them like knocks on the door of taking a deep breath is really good for you today. Your baby's lucky to have you. So we've created these with the March of Dimes at our Innova pilot. And we have 5 months of programmed SMS messages that will go out. So depending on how long a baby is staying in the NICU, that parent can expect to get a number of messages. And once they're discharged or there was a perinatal loss, we cut off those SMSs so they don't get them anymore. But they have really nice coping skills inside of them. Next slide, please. And the most important thing, this has been like the thing that had been missing this whole kind of time, especially for me, was when you screen positive, you get this response from a Mammha care coordinator. A Mammha care coordinator is the peer support specialist. They are trained in mindfulness. They are trained in maternal mental health. They know how to triage patients. Sorry, I was reading the question. And the average response time is in about 10 minutes. So mom or dad screens positive and immediately a Mammha care coordinator, hi, I'm Maureen, I'm here to support you. I'm going to be checking in on you now while your baby's in the hospital, but also when you go home. I'm going to be following you for the next couple of months. So it's continuity of care. So they're never being kind of let at like slipping through any kind of pipeline that will never find them again. They're always getting this touch point. And it's not AI, it's a real life person. This kind of population appreciates, we find like high touch, and that it's a real person is really important. We hear that a lot from parents. We're so thankful, like you're real, like it's another person. They're available during non-business hours. So the weekend, a lot of moms will text while in the NICU at 10 o'clock at night with their care coordinator. The average time for care coordination is about 6 weeks, but it can be as long as a mom needs it or a dad needs it to be. Next slide, please. So what does care coordination look like? The one thing that we do is we look for free virtual support groups, either from Postpartum Support International, we have our own, or we look to Hand to Hold. We give them these, like, you know, here are the groups coming up this week. This one might be one you'd like to try. We're very encouraging about it. If it doesn't feel right, you can always log off. This is what we've heard from other parents. They also help support with techniques. So if a mom or dad is having panic attacks, you know, this is something you can do to try the next time you're in it. These are some skills you can use for dealing with some of those thoughts that you're having. They can also help connect with therapy. So in some of these locations, we have our own therapists that are paneled with insurance payers. If not, we're referring out into the community, but we're never giving mom or dad the phone number, like a list of phone numbers. Here you go, like go make your calls. It's always us making that call. We never put that disease burden back on the parent. I think that's why we've seen in studies that only 15% of parents who screen positive engage in care. That doesn't work. That piece of paper with the phone numbers, it just doesn't work for people that are having a mental health complication. We found that we can get people engaged in care if we take that burden off. So that's something that we do. If they want to connect with a therapist, we'll help find that therapist and help coordinate that connection. And we'll make sure that the connection happened. And we're also going to make sure that it's a good match, because sometimes finding a therapist is like blind dating, and it's not always a good match. It's not always an appropriate fit. So they're never left to be like, oh, this is great, this person's terrible. We're always checking back in, and we'll replace them, rematch them if they need it. We celebrate when they're feeling better, and we're there to give hope when they need a lot more support. I think I'm reading what this question is. So we're in some different hospital systems. We're at Children's National in Washington, D.C. We're at the Inova Health Systems in Virginia. And we work with hospitals in South Florida through ICU Baby. So we're working with them. And we also work with pediatricians and with OBGYNs and OTs. We're working with a collaborative of pediatric OTs in Los Angeles. Next slide, please. So I will tell you, when we came to create Mammha, it was about increasing screening, which we've done. physicians, health systems, NICUs are more likely to screen when they don't have to do it alone, when it's not done with a piece of paper, when they know that there's appropriate follow-up care, that they don't have to figure out what to do with that patient if they do screen positive. So what we've seen, our patients are 5 times more likely to engage when Mammha is screening and doing the follow-up. And that's because we take the disease burden off of patients and we meet them where they're at. So if treatment could look like one-on-one from the peer support specialist, treatment could look like coming to support groups, it could look like getting on medicine, it could look like therapy, or a combination of all of those. Next slide, please. So just 2 stories. We had one mom who reached out, actually her husband reached out to us. It was about 22 months after she had delivered her son. He was in the NICU. She had to be medevaced to a different hospital right after. There was a lot of trauma. This mother slipped through the cracks. Her marriage was on the rocks. She had a lot of anger and a lot of anxiety and a lot of depression. And so we got to her 22 months later. And so that's a lot. That's a long time to suffer. That a lot of damage can happen. It was happening with her relationship. I'm sure it was happening with her relationship with her son. It was affecting her relationships with her family members. So this is what we're about, is making sure it doesn't get to that point. It doesn't have to get so bad as we can intervene a lot quicker and sooner. So the next slide, once we got to her, we were able to give her that support, connect her with a therapist, support the father, because the father had a lot of feelings. Anger is a really hard thing on couples. Rage is a symptom of postpartum depression. And so he needed his own support and his own healing. And the first time she felt hopeful. Someone's checking in on her and making sure the care plan is being spelled out and that it's followed through and that she's feeling better. The next slide is a mom that we were able to intervene with that was from Children's National, and the baby was born very early, and the mom had to stay in the hotel far away from her home, and she had a really hard time, and she would share it with her care coordinator when she was doing skin on skin with the baby at 10 o'clock at night in the NICU. Like, I feel like a terrible mom because I slept till 9 o'clock in the morning today. I just feel like I could be doing more. And that care coordinator would text her every night and say, you need rest too. You have to be able to take care of yourself. Let's look at the ways you are a really good mom. So what I really love about it is Leah could go to therapy, but you can only go to therapy like once a week. And so this is the in-between. So this is those nice check-ins, and it's from somebody who's supportive and who knows how to connect her with care, and who's going to be there and say, hey, it's Saturday night. How are you feeling today? How was today? Did you have any time for you today? Was there a win for today? Next slide. And she said, my care coordinator was always there for me. She helped me, and that it was okay to take a break, and that I am a good mom. She helped me feel less alone and scared. So that's really what we do. We had a mom today who just came home with her baby, and we did our check-in because we are going to follow this mom for the next couple of months. And she shared, the baby's home, but I am really angry. I am having so much anger come up from my experience. And so I love that we can be here for her for that part of the journey. So we can pick up where her experience in the NICU left off, and we can help her heal from that experience. So she's not on her own now. So we catch a lot of women where the shock and the trauma, they're in shock, and then they get home with their babies finally. And then that's when it gets quiet and everything starts to be felt. It wants to be felt. And so we're there to make sure if that stuff is coming up, let's help her and that father heal from that. Next slide. I promise we're almost done. The other thing we have is some great access to data, you guys. It's like fast, it's real, and it's so fast and wonderful. That's how we can see those screen scores, and we can start to piece together, like, where are the hot spots, where are the zip codes where this is more happening more, like what interventions could we do better, and then also what kind of treatment pathways help most, or like when do we start seeing women and fathers getting better. Like we've already started to see that dads, they just need this talking to normalize their feelings, and then they start to feel better. We've seen this, and with mothers, their scores might not be as high, they might not be saying they have suicidal thoughts, but theirs takes a little longer to start to unpack. So we're able to get these stories from the data and the work. Next slide. One thing we've had to do by working with our hospital partners, it's all about safety and liability. So we can turn off the screens so we don't have women or fathers screening at 2 o'clock in the morning. So we can set those hours. If a mother or father were to say that they have thoughts to self-harm, we have a mental health professional, a Mammha mental health professional, who calls that mother or father back right there and does a suicide risk assessment. So if there isn't an in-unit therapist or social worker, we help to create that extra mental health team to be able to like add that so that units can screen and can do this kind of work because they have us. So that is, I see there are questions and so. What day do they get screened in relation to their baby's admissions? They in Nova NICU, they do it 2 weeks after they've been in the unit. Some nurses will notice that parents need support before their screen time, and they can always make a direct referral to us and say, hey, I have a parent, we can enter them in, or they can enter them into the system manually. So but they've put it at the 2-week mark, and then we have automatic interval screening. So they let us know when they would like them to be rescreened, so we can keep checking in on them and seeing if there's a change in their scores. Does the screen attempt to identify and address prenatal social stresses that may have contributed to the preterm birth, or focus instead on the stress involved in having their baby in the NICU? So right now we're using the EPDS screen, but we're looking to add some other kinds of questions. I'm sure you guys have heard this big conversation around the EPDS, that it's not really culturally appropriate. There are questions that are like, are things getting on top of you? We don't even know what that means. Like some man in Edinburgh, Scotland wrote that a while ago. So we're looking for really unique ways to just say, this is what this question means. And we're looking to do that with our Spanish version of the EPDS, because it's not translating very well. But those are some great questions that we can add as additional questions to figure out if there's other things that we can pull. So that's a great idea. I'm actually going to take that. What is the process if a hospital wants to use your wonderful service? They can reach out to me at Maureen@getmammha.com. We're just excited to start. I even forgot, we're at UTMB, that hospital system in Galveston. We just started screening their moms in Texas, and it looks like it's going to be a really wonderful relationship. We've already caught some of their mothers, and we do work with women who have had perinatal loss. So we help to navigate that pathway to care and that healing process. Oh, that's so nice, Daphna. Thank you so much about the data collection. And are these services free to families? Yes, they are. So we're working to get it all covered by insurance. So we're able to provide this at a really low cost. And if a woman or a father needs that kind of therapy or some kind of treatment like that, then we can bill insurance for that care and get paneled with those payers like Medicaid and the more common plans. Are these Yes. Yeah. So we're never charging a parent for this. And the March of Dimes is covering our costs in some of these hospital pilots that we're doing. And I think that's it. Thank you so much.
Thank you so much, Maureen. I bet that you sleep amazingly at night, knowing how many lives you're changing and benefiting. This is just incredible work. Thank you so much. I believe that we are out of time. So I do just want to briefly mention our future webinars, the next one being on September 28th. Please use the QR code below to subscribe to our FCC task force mailing list so that you're not missing out on any opportunities to attend these incredible presentations. Thank you so much, everyone.
Bye.
Everyone.